So the valves that we take out of cows or pigs cannot be transplanted in a fresh state. If we take a valve from a cow or a pig and put it in a person, it's recognized as a foreign body, a foreign protein, and the body will then tend to reject it. We don't use immunosuppression the way we do with transplants when we do valve surgery. The way we get around that is they're preserved and treated with fixing agents. These are chemicals that the valve is immersed in by the company, and it kills the proteins or destroys the proteins on the surface of the valve so the human body doesn't recognize it as foreign. And that's the reason why you don't get rejection of heart valves. They used to use formaldehyde, and now they use glutaraldehyde, just a slightly different drug, but that's what it does. It destroys the proteins on the surface. This is a Hancock valve. This is a more modern valve, and I'll show you the one that we use today. Actually, it's not this one. This is a Bjork-Shiley valve. It's another valve that is no longer on the market because a lot of people had these put in the 70s and 80s, and then they had strut fractures. These things tended to crack, and so they took that off the market as well. And this is the Medtronic Hall valve. This is one of the mechanical valves that's available today. Introduced in 1977, and it's a single block of titanium here, and then the disc here is made of carbon, pyrolytic carbon, and that's what all the mechanical valves are these days. And this is actually a Medtronic Hall valve in place. I'm going to get this thing to play. So, this is a preparation of an actual human heart. This is a donor heart that wasn't used as a donor, but it was put on a perfusion apparatus at the University of Minnesota where they put non-blood perfusate through there with oxygen through it and allowed the heart to beat. This heart had a mechanical valve in it here as well. And this is just a catheter measuring the pressure there. You can't see it in the room because it's a little bit bright. I don't know. At least we'll turn the light off. I don't know if it's any darker or not. But you can see this is that valve I just showed you that's flipping open and closed. And that's what it actually looks like when it... Yeah, it's a little better. Thanks. So it opens partially. It's more efficient than the original valves, but it doesn't open completely. So you still, when you have any mechanical valve in place, it's not as efficient as the human valve that was there that opens completely. There's still some resistance to flow. The bileaflet valves, or the St. Jude valve, is the most common one we put in these days. This is the one, if we use a mechanical valve, we use the St. Jude valve. And it's got 2 leaflets in it. One of the advantages of 2 leaflets is if somebody has a blood clot on one, you won't die. With the single leaflet valve, if you get a blood clot that stops moving, then you will die from that. But with 2 leaflet, you've got 2 there. And they go back and forth like this as they go. That's what the current St. Jude region valve is. In the 1980s, there were refinements to prosthetic heart valves. There were advances both in the mechanical valves and in the tissue valves. And the Hancock valve, I think I showed you that, was developed in the 1970s. Over time, they learned to treat these with different medications that prevent calcium formation over time, because these big valves tend to calcify, they tend to block off over time. And currently, these are the ones, the 3rd generation pig valves that we use. This is Medtronic. This is one of the companies that makes them. Mosaic and Freestyle valves are the ones that we use most commonly here. This is a stepless valve. This is actually a pig aorta. So this is from a pig. This is the aorta where it comes out of the heart. This is the aortic valve here, and this is where the coronary arteries feed the heart itself. So what they do is they cut this out of a pig, they tie off the coronary arteries, and they put a piece of cloth on here to make it easier for us to sew it into a human heart. This stentless valve can improve the blood flow through there, the hemodynamics through there, because all the other valves you saw had a piece of cloth and some metal on there that take up some of the space that blood can be flowing through. Stentless valves don't have those stents on there, and as a result they have improved blood flow, improved hemodynamics through them. That's the advantage. The disadvantage is it's additional training required. They're more difficult to put in. There's some finessing things to get them to work properly, but if they work properly, they're a better valve in terms of hemodynamics. we put more and more of these in these days. And that's just another view of it. Same thing. This is the aortic root of the pig. This is the cloth that they sew on there. And then this is where the coronary arteries to the pig used to go. And then the person's coronary arteries will line up there and feed in the human that it goes in.
What is the actual size?
So the most common valve that we put in is a 23 or 21 millimeter valve. So about the size of your pinky or maybe your index finger for the center of it. And that varies a lot from person to person too. This is a stepless valve that I just showed you. And that same preparation, this is actually I think a pig heart that was put through that same preparation, but this looks amazingly like a normal human valve. That's the papillary muscles inside the heart. But you can see these are sutures here where those coronary arteries were. And if you didn't see those sutures in this cloth over here, there'd be no way to tell that wasn't a human valve. So the stemless valves really are good. This is a preparation showing that University of Minnesota preparation for a human heart. This is a camera that they stuck in the aortic root, down the aortic valve, looking at the aortic valve. And that's what a normal human aortic valve is supposed to look like. It's nice and thin. You can see the leaflets are paper thin. They're super thin. They're moving very quickly, and they're there's no inhibition of the movement at all. I just thought this was a really cool preparation I wanted to share with you guys. So these are the 3 leaflets. They're opening almost all the way, so there's very little impediment to flow. And that's what a normal valve is supposed to look like. When a valve becomes stenotic, you tend to get calcium buildup in the corners here. And we have a picture of a stenotic valve here, but it's not as bad as a lot of the patient's valves that we see. So same thing, the camera looks down through the aortic arch, down at the valve itself. And you can see there's calcium built up here, that yellow, and the leaflets are not opening all the way. This looks like a case of probably moderate aortic stenosis, looking at this heart. Oftentimes when we look in there, there are big chunks or rocks of calcium and the leaflets are barely moving. You look in there and say, how did this person go 85 years with this valve that was barely moving? And frequently people do just fine until it gets to a certain point that the symptoms get bad. So what about surgery for aortic stenosis? This is from the New England Journal of Medicine 2002. This is a survival curve for patients who had valve replacement and patients who didn't have valve replacement. This is percent survival, 40, 50, 80, 100% survival, and this is years out, 1, 2, 3, 4, 5. So people with severe aortic stenosis tended to die within 2 years without surgery. And people who had aortic valve replacement at 5 years still had 90% survival. This is the largest series. This was, I don't know the overall number on this one, but most of the series show the same thing. There are a few patients who are too high risk for aortic valve replacement, but many patients can undergo aortic valve replacement and have significantly improved survival and quality of life as well. When we're choosing what valve to put in, we think a lot about patient factors, and a lot of it has to do with what the patient wants. When I talk to somebody about a valve replacement, I go through all the issues about the mechanical valve and the anticoagulation, and the biological valve, or the non-mechanical valve, and wearing out. And so I let them make the decision. Patient age has something to do with it. In kids, we oftentimes don't put a PIG valve in. So, because if you have a 12-year-old and you put a PIG valve in and the rest of them grows, you're going to need to do a reoperation and put a bigger valve in. So in kids, sometimes we use mechanical valves because they tend to last longer. But it really varies. There are technical aspects in some patients. If the root itself, that is the heart itself, is very, very calcified. Sometimes it's hard to put a mechanical valve in there because the thing doesn't have a lot of give to it. And we may find we get in there, we have to put a pig valve in. And other people have a really small, tiny root, and if you compare a pig valve that we use to replace a valve with a mechanical valve, the mechanical valve has a little bit better flow. So some people have to get a mechanical valve because it's just so small. So there are some technical considerations. This is a picture of an aortic valve, a mechanical one being sewn in place. These are just sutures coming down here. And I have a video here of, this is a valve operation that involves sparing the valve and replacing the ascending aorta. And it kind of goes through things quickly here. I don't have video from our OR, I wish I did, but we don't have good video capability in the OR. So this is one that I found that I just want to be able to show you some of the things related to normal surgery. This is a CAT scan, a modern CAT scan showing the aortic valve. This is an aortic aneurysm. I don't know if I can pause this. It's a very large aorta, and this is the surgeon cutting the aorta open. This is looking down inside the valve, and this is what we typically see. These are the 3 leaflets of the valve. In this patient, the valve's not so bad. It was mainly the aortic aneurysm, or the enlargement of the aorta, that they're replacing. So they're not going to cut the aorta, cut the valve out here, but they're cutting out the aorta, the blood vessel above that. So they're going to cut the aorta out and then sew another graft in its place. But the pictures were pretty good. This is one of the coronary arteries that feeds the heart. They're disconnecting that from the aorta so they can cut the aorta out. And then they're going to sew a graft in there and plug the coronary arteries back into the aorta again. So this would be called a valve-sparing aortic aneurysm operation. We do a lot of these too. These are the sutures that you put in to implant either a valve or the aortic replacement graft as well.
Where does the replacement aorta come from?
That's it, right there. It's a piece of Dacron.
It's Dacron.
Yeah, that's the most common thing that we use these days. A whole bunch of different fabrics have been tried, and most of them are Dacron these days. Yeah. Sometimes we'll use that pig aorta that I showed you if we have to do the valve as well. We'll replace the whole thing with that.
Does a pig valve last? About?
Current one's probably 12 to 15 years.
In anticipation that the use of life may extend over the next few short years with the improvements in technology?
With the valves, yes. And in fact, that's why the current ones are up to about 12 to 15 years. 10 years ago, average was about 6 years.
Mm-hmm.
So, and that has to do with that fixation stuff that they do. In addition to the glutaraldehyde, they have this other material that inhibits calcium formation. Mm-hmm. And they're all proprietary. You know, every company's got their Edwards will tell you that it's better than Medtronic and that sort of thing. So that's the ascending aorta has been replaced there. That's sewn in around the valve. And then they're going to plug the coronary arteries into that as well.
While they're doing that operation, how is the heart? Did you take the person off the heart? You don't count on the heart to pump the blood?
Correct, that's right. So there are cannulas going in. The blood is going into the aorta up above here. They'll show it to you a little bit later. There's a clamp on the aorta. So there's no blood flowing through the heart. The blood is going from the heart-lung machine up into the aortic arch, through the whole body, and then draining out back into the heart-lung machine through the right atrium, through another cannula. So the heart has been isolated. That's what this is right here. This is draining all the blood from the patient back into the heart-lung machine. So that allows us to oxygenate it, take the carbon dioxide out, and also adjust the temperature. Whenever we do these operations, we cool the patient down as well, because it decreases oxygen requirement for the brain and all the vital organs as well.
Does this operation of the putting in a valve, does that have anything to do with blood pressure? Does the blood pressure control get better if you have a valve? Or
Some people do, yeah.
In relationship with the blood pressure?
In some people that we do notice a difference, particularly in people with aortic stenosis, with the blockage there, they can have very high blood pressure because the body's trying to compensate for that blockage. Many times when they get their valve replaced, they don't need to take as much blood pressure medication because the body reaches a new, without the impediment to blood flow, reaches a new standard for blood pressure. But some people still have hypertension afterwards too, so it really varies.